Okay, welcome to Spine Conference. Today's topic is going to be unilateral laminectomy, bilateral decompression. And I apologize in advance. I'm having some slight audio-visual problems, but I think we're going to be okay. So we're going to go over the surgical technique today. And I think you guys are going to like this. But first, we're going to see the patient themselves, the illustrative case. So this is a 72-year-old woman with right buttock pain. She's relatively healthy. She's had previous cervical laminectomy, I think, or ACDF. She had a previous cervical surgery 3 months ago, and she did well from that. Do you recall, Aaron, the details? Okay. Anyway, she did very well. So she presented with the office with low back pain, right buttock pain. And what are your findings on the X-ray, Aaron? Tell everybody.
What's that?
Decreased disc height at every level. L5S1. 4-5 is not too bad. 3-4 is decreased. 2-3 is decreased. AP view. AP view what? Sclerosis of the facet. Good morning, Patty. Thanks for bringing the papers. Okay, so some decreased disc height at every level. This is sagittal cuts on the MRI. Come closer and talk to the microphone. Same thing. Now you see the, yeah, but see the 4-5 disc looks pretty normal, right? Yeah. Mild bulging, but the discs are, you can see they're deteriorated and decreased in height. 2-3, 3-4, 5-1. Interesting. Show some retrolisthesis. L2. Good morning, Dr. Allen. Some retrolisthesis at 2-3. And posteriorly, show the ligamentum flavum hypertrophy, the black ligament. Right. So you can tell, you can see the black, you see the posterior spinous processes, right? And between them is a black, is a ligament that's black. And you can see, this is actually, I didn't realize this, but this is a really good example of the ligamentum flavum. You can see, do you see how nice and rectangular they are? The nice rectangular, that's what they should look like. Here, you see how they're circular? You see at 3-4 and 4-5, they're circular? That's not normal. And that's actually a very good example of how you can see on the sagittal cut hypertrophy of the ligamentum flavum. So between our bones, we have these ligaments that keep our bones in place, basically, like the knee. And, you know, the most common one everyone thinks about is your knee, ACL, anterior cruciate ligament, which keeps the femur and the tibia intact. But between the posterior spinous processes and the lamina, we have a ligamentum flavum, or yellow ligament, that attaches, and it can hypertrophy. And if you hypertrophy your ACL, no big deal. If you hypertrophy your ligamentum flavum, it compresses on nerve roots, and it's a problem. So, does everyone see that? I think that's it's a very nice representation. You can see it on the sagittal cuts. Usually you don't see it you don't recognize it on sagittal cuts. So here's an axial cut, and the spinal canal where the nerves are is nice and round, and you can see the little nerves themselves. They're like pieces of spaghetti. This is at L5S1. This is a normal spinal canal. This is the next level up, L4, L5, and you see how there's no room for the nerve roots. It's just a very small thecal sac, and you don't even see any CSF. And that triangle in the back is fat. There's like a little bit of fat there. And you're going to see that fat intraoperatively. And that thing, the black stuff? Yeah. Ligamentum flavum. So that's that same ligamentum flavum that we saw as bunched up and round on the sagittal cuts. And you see it here on the axial cuts. And this is 3-4. Next level up, you see very little room for CSF, almost no room for CSF. All the nerve roots are crowded. Hypertrophy of the facets, ligamentum flavum, which is compressing the thecal sac. So very small spinal canal. And then here's a normal spinal canal. And it's a big difference. You can see CSF all about the nerve roots. You can easily see the thecal sac. So any questions so far about spinal stenosis that we see in this patient? 3, 4, and 4, 5. So the spinal canal is very small. And this is a cause, this is a significant contributor to our symptoms. So the question is having abnormalities in your spine normal? Is it normal? So this is the classic article from Bowden from 1990 where he took MRIs of normal people. And normal people, you know, what is a normal person? By definition in this study, it's someone who doesn't have back pain, who's never had back pain. And he did MRIs on everybody, less than 40 years old, greater than 40 years old. And he found that most people had some type of problem. So I'm not even going to get into under 40 because that's so young, it's not even worth talking about. But let's say normal people over, because we're here over 40 crowd. But over 40 crowd, it's you know, there's abnormalities on the MRI scan. Like 37% have degenerative disc disease. So it's very, very common for people to have abnormalities on the MRI scan. So the question is, as a physician, you have to understand what's symptomatic in people and does it correlate to the symptoms. So in this patient, it correlated very well to her symptoms because she felt she was when she extended it was worse. It went down her lower extremities. So that's just normal. So this is just posture. This is from a chiropractor's website. I don't agree with the letters, with the descriptions, but I want to show you the cartoon because the cartoon is pretty good. The guy on the left has lumbar stenosis, and does have a flat back, and he's leaning forwards. And the reason he does that is because when you lean forwards in your lumbar spine, it opens your spinal canal. It stretches the ligamentum flavum. That's why people lean like that. The guy in the middle is normal. Now, the guy on the right, interestingly, the guy on the right has thoracic kyphosis. And because the thoracic spine is kyphotic, he has to make up by doing sway back, accelerated hyperlordosis of the lumbar spine. So these are all normal postures. Interesting, the chiropractor does very well describe them and see them, but I think the chiropractor does not understand why they exist. But you know, it's a different field, so maybe he's got other other things on his mind. But these are all interesting. So just when people have spinal stenosis, they have pain down the legs and they lean forwards. This is just a reminder that the spine has a thecal sac inside of it. And in the spine, there's a hole for every vertebral body bone, which is a spinal canal. The nerves run through there. And this is just, I won't get into this, the history, but there's just, this is a cervical spine, and this is my previous office worker. She's looking through the spinal canal. So there's a tube where the nerves run. And then at every level, there's a frame and there's a hole where a nerve exits. So this is just, if you could magically remove the thecal sac and look at it, this is what it would look like at every level, the shape of it anyway. And then this I want to bring this to your attention. This is from a French spine book, which is excellent, René Louis, and it's an very old book, but he described how big is the spinal canal. So we're looking at L4, L5, and we'll do L4. And the transverse diameter is 23 millimeters, should be 23 millimeters on average, and 15 millimeters in the AP diameter. So these are just numbers that are important. And I'm going to go over why these numbers are important. So just, I'm going to fly through this, but this is just clinically. When people come with low back pain, who are the problem people? People who say the pain's terrible at night, wakes them up in the night as throbbing pain, pain at rest, progressive neurological deficits, the weakness or numbness is getting worse, and you're suspicious for a cancer or an infection. So who's suspicious? If they have a history of cancer, if they're immunosuppressed, ankylosing spondylitis, you're always worried about a fracture. If the patient has no pain at rest, if they're writhing in pain, Unexplained weight loss. IV drug abusers always suspect an abscess, and concurrent urinary tract infection, sepsis, always suspicious for an abscess. So in these patients, these are different. This is a different animal person. Like when you see these people, you're thinking surgical emergency. These are rare, but just it should be on your thought process. The pain is worse with extension in the lumbar spine. And this is just a axial cut which shows the spinal canal. It's a tube where the nerve runs. So I know I'm going very quickly, but because I have a lot of video on show. Any questions so far about lumbar stenosis? Okay, so the approach is posterior to open the canal. The standard approach is laminectomy, where you remove the whole lamina. And this shows you what you do. You remove the whole posterior spinal process and the whole lamina. This weakens the spine and frequently needs a fusion. But this is the standard approach, full laminectomy. Now this is my former partner, Charles Edwards, who taught me the porthole technique, where you don't remove the whole lamina, but you drill a hole all the way where the facets are to open the spinal canal. And if you do it in this manner, you don't have to fuse the spine. And the guy on the right is the fellow who wrote it up in the Spine Journal in 2000. So this is a porthole technique, which works fine. Now, so the right is laminectomy, the bottom right is porthole, and the left is unilateral laminectomy, bilateral decompression. So basically, you open up the whole spinal canal through a hole just on one side. So these all have evolved over the course of the last, I don't know, 15 years. And this shows you how you open the spinal canal from a one-side approach. Now, I started doing this on my own when the microscopes got better. It was an evolution of the porthole technique. I thought I invented this technique, and I was doing it on my own. But it turns out people were doing it in '95, and people do it all over the world, really. And it's because the reason why this is getting popular is the microscopes have gotten better, so it's easy to do this. It used to be hard to do it. So the surgery is done in the prone position, and this is our Jackson table that we use for surgery for the prone position. The benefits of this Jackson table is that it bends easily, so you can open up the spine. It rotates easily, so you can get the position just right with the microscope to get the opposite side, and it's a very secure. And here's me on the table. You see how it's very secure. It kind of hugs my body. So if you turn the patient, you're not worried they'll fall off the table. And the table turns very slowly. And this is the C-arm we use. This is the actual microscope goes over the patient. This is what it looks like during the surgery. The surgeon's standing straight up, which makes it very easy. If the surgeon's comfortable, the surgeon can do a good job. So this kind of shows you the approach. It's just one side. You approach one side of the spine, remove the ligamentum flavum. Now this is normal. See how the spinal canal is big? And you see how the ligamentum flavum is normal. See how it's just stretched out. It's not compressed in the thecal sac. And this is the axial cuts through a normal spine. You see every level of the spinal canal is the same, which is not the case in our patient. And these are just articles. Reviewing the technique. The reason why I put this is it shows you how you do it. You just open up one side, and then you turn the table, and you decompress the other side. So it kind of shows you how you open up the spinal canal, keeping everything intact. So in the literature, Ralph Mobes in Sydney, he's written the most about this technique, and he's had a lot of excellent articles just explaining how patients do better, less blood loss, they rebound faster, and they don't need fusions. And these are just the details. I'm not getting into them. So this technique, the pitfalls are if you do it from unilateral side, there's always a chance that the opposite side can get stenotic. You can get a dural tear because the technique's more difficult. You can get a nerve injury. You can fracture the pars. Maybe you don't decompress it as well if you're not used to it, and the foramen may not be decompressed. So it's technically challenging, but if you do it well, the patient does not need a fusion, and they rebound very fast because you just do everything through a small hole. So this is the lady. Just intraoperatively, I just put a clamp on the spine to confirm where we are. So the first step with the burr, and you're going to see this with the video, but the first step with the burr, you see the burr, is you make a working window. So you start at the top and you drill the posterior spinous process. You're making a window basically to look through. So you start in the middle. And this is how I do it. No one taught me how to do it. God and myself taught it. So if someone can tell me how to do it better, I'll be glad to hear them. But this is how over the years I've found works the best. And you go all the way down to the lamina. So you see you're starting to make a window here. Now the next step is you open up the lamina. You have to keep the pars intact. The pars is laterally. You don't want to break that, get a pars fracture, because then you have instability. Now remember we said 23 millimeters? The dura is 23 millimeters. So basically on one side you need 11 millimeters. So under the microscope it's no more than 3 burr diameters because the burr is 3 millimeters. So that's kind of like a simple dirty way. So you make a trough. I make a trough on one side of the lamina so I know where the pars is. Aaron, show me where the pars is on the lateral, or on the top where I'm doing surgery. So if you break the pars, it's a problem. So you want to keep that intact, that part of the spine intact. You stay medial to the facet, and you try to go up to the ligamentum flavum. I'll show you what that means in a minute. So I'm just making it bigger, and then I connect the two areas. So the lamina is still there, but it's kind of bleeding. And this kind of shows you what's going on as far as the canal is concerned. And then in the canal, there's the ligamentum flavum, which protects the dura. So you want to leave the ligamentum flavum intact as long as possible. So once the lamina is filled, then you go to the top and you find the dura and you remove all the bone first, keeping the ligamentum flavum intact because the ligamentum flavum protects you from the dura. I'll show you all this with the video. And this is me removing the bone. Now you're looking at yellow ligament. See the yellow ligament? And then you remove that with a kerrison. And when you remove the yellow ligament, you're looking right at dura and you're fully decompressed. And then the lateral border you shave with a kerrison punch. So one side's open. Now you got to go to the other side. So you can imagine on the other side, all the muscles are intact. So only half the spine's exposed, and that decreases morbidity for the patient. So then you burr down the other side from the opposite side, and you remove all the bone there, opening up the channel. You're left with the ligament, and then you remove the ligament with a kerrison. Does this make sense? A little bit? Okay. I use these suction tips. They're plastic, and the reason why you'll see during the surgery, I use these suction tips because they don't injure the nerves. They're soft, and I can manipulate nerves with the plastic suction tip. And this is just the most recent article this year that Mobes published in the Chinese Orthopedic Association journal, which I didn't even know this journal existed. It just shows the technique, which I kind of went over. This is his technique. And just as one point he said is, you look at the posterior spinous process when you choose which level. If it's angulated, you may want to go the easiest place where you can make a window. It's the attachment of the extensor musculature. So we need extension muscles, and it's got to attach to some bone. That's where it attaches to. Like if you look at a dinosaur, who's got really big extensor muscles, they have huge posterior spinous processes. Huge. That's one of my favorite things to do in the world is Smithsonian and look at all the bones in the osteology exhibit. Okay, so next is the video.